It makes a lot of sense to talk about acute liver failure after Dr. Hannigan's lecture. So it's just like a continuum. I'll be talking about acute liver failure, nothing to disclose. Our objectives here is to understand the pathophysiology and definition of acute liver failure and to identify the most common etiologies and how to approach and manage the complication with early recognition criteria for liver transplant. First of all, we'd like to know how much of it is a burden, this disease worldwide. They call it the orphan disease, as not really a lot of cases. It's rare, around 2,000, 3,000 cases in the United States per year, 1 in 8 cases in the United Kingdom per year. So it's not really common, but when it happens, it has really a devastating course if it's not treated well. And not surprisingly, that the last guidelines from the AASLD goes back to 2011. And the recent one is from the EASL, as well as the American Gastroenterology Association 2017, which we will depend on mainly. A very nice snapshot was released in the Journal of Hepatology in 2021. Basically, it tells that the better understanding of the pathophysiology of acute liver failure helps in reducing the worst outcome in the disease. So basically, we have a massive necrosis of the hepatocyte depending on the etiology, and this leads to hepatocyte death, inadequate hepatic regeneration, formation of damage-associated molecular pattern leading to monocyte, neutrophil, macrophage activation, which will lead to hepatic and systemic inflammation, superimposed infection, and the whole scenario will lead to hepatic and extrahepatic organ failure. But the good news from the slide that the illness is changing and survival is improving, as liver transplantation is often less required with the improvement of the medical support, and bleeding complications are now uncommon, only less than 10%. Cerebral edema, which is the leading cause of death, is now becoming rarer, as well as established treatment are now often used in different ways. The first problem we encounter in acute liver failure is the definition, because a lot of times we were called about cases that doesn't fulfill the criteria. The patient have everything, but there's no encephalopathy. In this case, we call it acute liver injury. So we have to be careful in the definition. So it's an acute severe hepatic dysfunction characterized by coagulopathy with the INR 1.5 and more, encephalopathy based on West Haven criteria, without pre-existing liver disease, and the illness course is less than 26 weeks. So the exceptions here are Wilson's, autoimmune hepatitis, and HBV reactivation, as in these three scenarios, there is an element of chronic liver disease, but when they decompensate, they behave as an acute liver failure. So these are the exceptions in such scenarios. This is the West Haven criteria. We have to know the grade of encephalopathy. As you can see, as you go further, especially in grade 3 and 4, the risk of cerebral edema, intracranial hypertension, and hence risk of herniation and death gets higher, especially in grade 3 and 4. There is a subclassification of acute liver failure. It could be hyperacute, acute, and subacute based on the duration. A classic example of the hyperacute, which lasts for a week, is the paracetamol, hepatitis A and E. They have high severity of coagulopathy, degree of intracranial hypertension, but the chance of spontaneous recovery with the hyperacute is better. The acute lasts for 4 weeks, and beyond that is the subacute course, which they have more jaundice and they have poor chance of spontaneous recovery. And a classic example is the non-paracetamol drug-induced. A reminder of the causes of acute liver failure. Remember the viral causes, very common, hepatitis A, B, D, and E. Also, other viruses are implicated, CMV, EBV, HSV, VZV, and dengue virus as well. Regarding the drugs and toxin, acetaminophen or paracetamol, I'll use it interchangeably to please the North American and European, but I'll stick to paracetamol as we use it more commonly here. Remember the dose-dependent versus idiosyncratic reaction for the drugs. A classic cause of dose-dependent is the paracetamol, while drugs like isoniazid and phenytoin act as idiosyncratic reaction. Amanita phalloides, the mushroom poisoning in the States seen more commonly. Autoimmune hepatitis, Wilson disease, Budd-Chiari, a classic example of the vascular causes. Ischemic hepatitis, pregnancy, very important topic, including fatty liver of pregnancy, which can happen even after delivery of the fetus. So we have to be careful with this. HELLP syndrome, preeclampsia, other causes include malignant infiltration and indeterminate causes. A very nice questionnaire released by EASL 2017, what to ask the question or relative in the beginning. We know Majority of the cases, patients are encephalopathic, difficult to obtain history, but if you are able to get it from the patient or a third party, this will be really important because first you need to search for the etiology, asking about medication, substance, any suicidal attempts, then you move to causes of acute liver failure. So questions are important about pregnancy, traveling to endemic area, hepatitis B and E, received immunosuppressive therapy for hepatitis B reactivation, and history of autoimmune disease. Also, initially, you have to touch on the feasibility of liver transplantation for the patient. So you should ask about chronic liver disease, alcohol, history of cancer, severe heart disease, or lung disease. And of course, the interval between the onset of jaundice and the first sign of encephalopathy for the subclassification. In case you're interested, this is the mushroom poisoning, Amanita phalloides. They call it the death cap. We see it here only in textbooks or MCQs. Probably in the West Coast, in the States, it's more common. But we are actually really interested in is the paracetamol, and which is the most commonly prescribed drug worldwide. You can take thousands of tablets and nobody will ask you why. In many countries, there is no restriction. And people are being poetic about it. She's like paracetamol to all my pain, but yet the true pain happens when the patient comes to the ER overdosed. Looking at the incidence of such causes of acute liver failure in the States and United Kingdom, the leading cause is paracetamol or acetaminophen. But if you go to eastern side in Asia, like Bangladesh and India, you see that hepatitis E is the leading cause of acute liver failure. In Japan, it's hepatitis B. So really, it makes a difference from which part of the world you are to prioritize the etiologies of acute liver failure in your mind. Remember the common drugs say to the acute liver failure, touched already by Professor Hannigan, but also remember the herbals, very important cause. So you have to dig more in the history to look for herbal medicine. I really recommend that you visit the website LiverTox, very important database to look for any drug and its relation to hepatotoxicity and acute liver failure. Now for the management. The main idea in management is to give time for the liver to regenerate and do all the neuroprotective measure to help the brain and other body parts. Your initial assessment, remember the following. First, evolution of acute liver failure is highly unpredictable. You will never know what will happen in the next few hours. So you have to be ready from the beginning. Exclude cirrhosis, alcohol-induced liver injury, or malignant infiltration, as this will affect the decision of transplantation later on. Radiology of subacute liver failure can mimic cirrhosis. You have to be careful if you have a jaundiced patient with subacute presentation. You might be seeing a shrunken liver, regenerative nodules, so you have to discuss with the radiologist. It's actually an acute liver failure, not cirrhotic changes. Early discussion with the transplant team to assess suitability and screen for hepatic encephalopathy from the beginning, determine the etiology to guide the treatment and prognosis. For this, remember to order coagulation profile, liver profile, urea, urine output, ABG, lactate, and ammonia for prognostic reasons. Urine for etiology, remember toxic screen, paracetamol level, hepatitis screening, autoimmune, ceruloplasmin beta HCG. And one word about ceruloplasmin, remember it can get lower in other than Wilson disease causes. So remember, to diagnose Wilson, don't depend only on ceruloplasmin. You can look for other clues like hemolytic anemia, Coombs negative hemolytic anemia, bilirubin to alkaline phosphatase ratio, urinary copper to help you to correctly diagnose Wilson disease. Imaging, including ultrasound for both Chiari and Doppler, CT for malignant infiltration, liver biopsy if in doubt and no certain etiology. You have to be careful here, putting the risk of coagulopathy there. Can go for transjugular approach if you need it. Weigh the benefit and risk, because if you are thinking about autoimmune hepatitis, which can happen sometime, negative anti-smooth muscle antibody, but still you have doubt, probably you need to go for biopsy, but with cautious steps. Now for paracetamol overdose, remember acute liver failure classically happen at 10 grams and above per day, but you can see it at even lower doses, especially if the patient is alcoholic or malnourished, because they are already glutathione depleted. Remember, it could be intentional or there is a therapeutic adventure. We usually apply the Romac-Matthew nomogram, but there is two drawbacks here. First, you have to know exactly the time of ingestion, which is not possible all the time. And also, Romac-Matthew is only helpful for the single event of paracetamol overdose. It doesn't help you in cumulative doses of paracetamol. Activated charcoal less than 4 hours, and definitely N-acetylcysteine is the cornerstone of treatment. Remember, there are phases of paracetamol toxicity. So if you have a patient coming in phase 1 with normal liver enzyme, don't jump and say this is not paracetamol induced. As phases goes on, especially after 24, 72 hours, you expect to find elevated liver enzyme, coagulopathy, encephalopathy, and ATN. So the best place for the patient to be in is in the ICU. So remember the general measures: fluid resuscitation, airway protection, regular check, neurological and vital signs, baseline cultures, chest x-ray, ECG, avoid sedatives, nephrotoxic, hepatotoxic drugs, check glucose, risk of hypoglycemia is very common, stress ulcer prophylaxis, PPI, early enteral feeding, especially with early stages of encephalopathy, and there is a very good role of N-acetylcysteine even in early stages on non-paracetamol cases. A very nice study was published by William Lee and his colleagues in 2009. It was placebo-controlled prospective randomized controlled trial on 173 patients with acute liver failure and no history of acetaminophen overdose, stratified by coma grade into 2 groups, N-acetylcysteine group and placebo dextrose 72-hour infusion. The primary outcome was overall survival at 3 weeks, and the secondary outcome was the transplant-free survival and rate of transplantation. So what was seen in the study that the overall survival at 3 weeks was not different between the both groups. What was really different that the transplant-free survival was significantly better for N-acetylcysteine patients compared to the placebo. So the message here that IV N-acetylcysteine improves transplant-free survival in patients with early stage of non-acetaminophen related acute liver failure. As you proceed with advanced coma grades, it has not much of a rule actually. For organ-specific management, so you expect an element of vasodilation and hypotension. So you start with crystalloid volume resuscitation, and this doesn't work, go with vasopressor. The vasopressor recommended in acute liver failure is noradrenaline. Definitely you can use the rest, but with caution. Hydrocortisone therapy doesn't actually reduce mortality, but can help in septic doses sometimes. And respiratory, remember to use invasive airway management. It's very important. There is also risk of ARDS in such patients. For gastrointestinal manifestation, oral nutrition should be encouraged early in patient acute liver failure. And if there's progressive of hepatic encephalopathy, you expect a decrease in caloric intake, but avoid NG feeding in those patients with progressive encephalopathy. PP administration should be given, but you have to balance the risk of VAP and C. diff infection. And consider stepping with the enteral feeding has been established. Remember, hypoglycemia is very common. Dextrose infusion should be there all the time, correct hyponatremia. And also remember the lactate will be high and it will be a poor prognostic marker. Renal replacement therapy also is indicated in case of acidosis or metabolic disturbance. Renal impairment is very common in patients with acute liver failure. 40 to 80% of patients develop it, and it's actually more with increased age. It's paracetamol-induced SIRS, hypotension, infection, and continuous renal replacement therapy should always be undertaken compared to the intermittent hemodialysis. For coagulopathy, abnormal coagulation, it's very important to know this, that it doesn't translate to increased risk of bleeding, as most patient coagulation is normal despite abnormal INR and PT. Commonly seen in acute liver failure, they have thrombocytopenia, reduced pro and anticoagulant. As you can see in the figure here, that the pro and anticoagulants in the first 48 hours in acute liver failure gets down, as this is expected thing. So what to do in case of coagulopathy? Actually, it's not recommended to do a prophylactic correction for coagulation or platelet level, but the only indication to do correction of coagulopathy if the patient is undergoing invasive procedure like ICP monitoring or if there is active bleeding. Hemoglobin target 7, venous thrombosis should be considered in the daily review. So for sepsis and risk of infection, patients are at high risk of infection, but actually antibiotics, non-absorbable antibiotic, antifungal have not been shown to improve survival in acute liver failure. So there are few indications to give antibiotic in acute liver failure. First, if there is progression of hepatic encephalopathy, clinical size of infection or element of SIRS, and if the patient awaiting transplant. Antifungal therapy should be considered with a prolonged ICU stay. For hepatic encephalopathy, remember in grade 3, you need to intubate the patient, use propofol as a sedative agent and short-acting opiate for analgesia. If you have any seizure concern, remember to give the anti-epileptic that has the lower risk of hepatotoxicity, like for example, levetiracetam, and EEG monitor. For intracranial hypertension, as you can see from the figure, that there is decrease in the incidence of intracranial hypertension in patients with acute liver failure, mainly because of improvements in the preventative medical care and use of emergency liver transplant high-risk patient who is at risk of developing intracranial hypertension. Patient with hyperacute or acute presentation, younger patient, those with renal impairment and need for entropic support, and if there is persistent elevation of arterial ammonia, namely 150 to 200. A very nice article was published in AASLD by William Bernal and his colleagues regarding the relationship of arterial ammonia and its relation to intracranial hypertension. As you can see, the dotted line represent the ammonia level of more than 200, as this is the worst case scenario where intracranial hypertension happen as days progresses in the ICU stay of the patient. So what to do in case of intracranial hypertension? For monitoring, you can use a transcranial Doppler, which is a non-invasive method, or invasive intracranial pressure monitoring with a caution of bleeding risk. Can use mannitol as a first line as a bolus infusion. Hypertonic saline has a role, and maintain the sodium between 145, 155. Remember to give hypertonic saline in cases of hepatic encephalopathy grade 3 and 4, ammonia more than 150, acute kidney injury requiring renal replacement therapy. Our idea here is to maintain the cerebral perfusion pressure above 50 and 60, so you should have a high MAP more than 75 with low intracranial pressure less than 20. And the CRRT is the preferred method for ammonia clearance. Your target here is below 100. Other options include hypothermia, barbiturates, and hyperventilation. These are some etiologies of acute liver failure and some medical management that you can mention. Remember, steroids, as Dr. Hannigan mentioned, are unlikely to help in drug-induced liver injury. For viral hepatitis, consider, for example, a cyclovir if you are suspecting HSV, can give it even before the release of the results. In Wilson disease, liver transplantation is actually the cure in acute liver failure, no role of chelation. In acute fatty liver pregnancy, apply the Swansea criteria, and remember, delivery of the fetus is the key here, but it can also happen after delivery as well. Acute ischemic hematitis, improve the hemodynamics. Chiari, you have anticoagulant therapy, you have also thrombolysis or TIPS can be used. So what about liver assist devices? Always the question will be, will there be any life on Mars? Mars is one of the technologies that's used here. So we have extracorporeal albumin dialysis like Mars, the molecular adsorbent recirculating system, or the Prometheus, or the SPAD, the single pass albumin dialysis, or the bioartificial liver support, ELAD. So where do you position these technologies? The idea here is doing something similar to dialysis, but mainly to clear the albumin-bound toxins in the liver. Mars is the most studied device, and the problem with all of these technologies, the cost and the complexity sometimes. So what is the position or statement of the EASL for liver assist devices, which are used mainly to bridge a patient before transplantation, or reduce or improve or recover the liver function in case you cannot transplant the patient? So the experience with liver support device has been disappointing. This is as per 2017 statement, and liver support system, either biological or adsorbent, should only be used in the context of RCT actually. The only evidence here is with the plasma exchange in RCT. It has been shown to improve transplant-free survival in patients with acute liver failure and to modulate immune dysfunction.
Dr. Abdullah, you have 2 minutes.
Sure. So for liver transplantation, the survival is high. The 1-year survival with emergency liver transplant, acute liver failure is more than 80% as year goes on. The prognosis is worse if you have patient with severe liver injury, extrahepatic organ failure, or subacute presentation. With irreversible liver injury is contraindication to proceed with transplant. Here you can see the transplant-free survival is higher with acetaminophen, paracetamol, HAV, ischemia, and acute fatty liver pregnancy in comparison to hepatitis B, AIH, drug, or indeterminate causes. Remember the King's College criteria, very important. You have to apply it in case of emergency transplant. The pH less than 7.3, lactate more than 3, or the following 3, hepatic encephalopathy grade 3, creatinine 300, 3.4, INR more than 6.5. Also in France, they use the Clichy criteria, basically on factor 5, which has the shortest half-life. There's a new kid in town, the acute liver failure study group model, which was published in 2016. There's an application for that. They use simple criteria for hepatic encephalopathy, etiology, vasopressor, bilirubin, INR, and they will predict the transplant-free survival in 21 days. It did well against the other models, so the statement here, use it as an additional add-on because it needs external validation. Still use the conventional one, but you can use it as an add-on. The take-home message here, make sure to apply the correct definition of acute liver failure. History is key in finding the etiology. Early involvement of specialized transplant center is crucial. Prognosis varies depending on the cause, and the right patient selection is needed for liver transplant. Thank you.